just once for all, unless you are not a clinical pharmacist, okay? And in overall, we call our care pharmaceutical care. And the nurses do administration of the drugs, they monitor, and they deliver nursing care. And in all this, our ultimate goal is to improve our patient health outcome. Okay, there is this newspaper publications here left. One say, please move ahead. Cancer boy dies after blunder over injection. Please can change the slide. Patient dies following fatal injection band. Teenage patient dies after doctor's injection mistake, and so on and so forth. What are we going to get from all these newspaper publications? There is a gap. The clinical pharmacist, I don't think he or she was in the picture, because if there's a clinical pharmacist around this physician, all those mistakes would have been prevented. So that is why there must be collaboration. Must. This diagram, the next slide, you can see this graph. Death from medicines, medications in the UK from 1999 to 2000. The one on blue is because of medication error. You can see the increase in rate of death of our patient. Next slide. And the red one, patient died because of medications. Next slide. So if there is a clinical pharmacist here, these medication errors, adverse effect of medicine in therapeutic use would have been reduced minimally. So we can never underestimate the role of a clinical pharmacist in medical care. And for our patients to get the best outcome, there must be collaborative practice within the healthcare professional. The next slide. Okay, so when we are talking about interprofessional collaboration, we are all in a team. Our main goal is to is patient-centered. Patient is at the center. We want to apply quality improvements. We want to use evidence-based practice. We want to bring in information as per your own specialty, as per your own profession on the table. The physician will bring their own, the pharmacists bring theirs, the lab scientists, everybody, just for us to get the best of our patients so that they can go home. Even in the hospital, those in the community will still get, even if you're in the community practice, you have to start collaborating with other healthcare professionals. You may see a case that you need to refer to specialists. You may see a case that you need to send that patient for lab investigation. It's collaboration. Yes, because you don't want to take all the responsibilities alone. You want to be sure that your patient get the best. Sometimes it's okay, please send. Nothing prevent pharmacy from sending a patient to do certain laboratory investigation if you're in the community pharmacy. If you receive a prescription outpatient, and the community, you want to know more about that prescription, you have some doubts, nothing stop you from calling the prescriber if you have access, or writing something, close it, give the patient to go back to that prescriber and get back the information back. That's collaboration. Okay, so in all, next slides, in everything, there must be integration, there must be cooperation, there must be coordination and collaboration. Okay, all of these involve coordination of expertise to optimize care. Even the medical practitioners themselves, that's the physicians, they collaborate a lot within themselves. And I pray that our pharmacy profession will look into this and start to collaborate even within the pharmacy profession. My husband is a cardiothoracic surgeon. Okay, if he sees the cases for general surgery or internal medicine, he will refer immediately. Not that he may not handle such cases, but they know, everybody know their own boundaries. They refer within themselves. Talk less of interprofessional. Okay, I thank God that we pharmacists, we are now going into specialization. Like myself, I'm a critical care pharmacist, and if I get information or query about oncology, I'll say, please, let me give you my colleague's phone number, who is an oncology pharmacist. I just give it out because I know I may not be able to get the correct information at that point in time for that patient. So we should start to refer patients to our colleagues who are specialized in one area or the other, or even to other healthcare professionals, and try to get back the information back, collaborate. That's the best way we can give our patients the best. Okay, we have 5 steps. The next slide, 5 steps to interprofessional collaboration. One, step one, professional awareness. Clinical pharmacy practice, are we aware? And that's what we are doing now, that we need to start to collaborate. We used to collaborate, but we must have to step it up. Very, very important. I work in ICU. There we do receive patients from different field of medicine. We do have neuro cases. The neurosurgeons come in to see those patients. We can have oncology, they will come in. We may have like stroke patients. You see different specialties coming in to see their patients. After every they will go. The intensivists, we that are in the ICU, will continue the management. We'll do ward rounds together, discuss to know the best approach for patients. So we must have to create that awareness, and that should start when we start to really start specializing, so that you know your onions. Then you must have to collaborate with other professional or even your colleague who has specialized in another field of pharmacy or medicine in order to help that your particular patient. Professional recognition, very, very important. I'm a critical care pharmacist. Do you recognize who I am? You, the oncology pharmacist, do we recognize that pharmacist as an oncology pharmacist? That's the only way you can collaborate. That's the only way you can refer. Okay? We have the 4th one, professional relationship expansion. Commitment to a collaborative working relationship. There must be commitment. Like in my own unit in the ICU, we are committed to work as a team. Like early in the morning, we pharmacists will do our own pharmacists only ward round for us to get acquainted with our patients, see their drug therapy, know their history, and identify drug therapy problems and await the multidisciplinary team. All of them, we are happy to come together to look into our patient case. Okay, so everybody will contribute. So we always look forward to start multidisciplinary ward round. We are committed to it. All the healthcare professionals, the nurses, the physiotherapists, everybody. So there must be a commitment. And the next slide, we, the clinical pharmacists, we are one of the integral members of the healthcare teams. We must participate in the interdisciplinary rounds. We contribute to mediated discussion and provide valuable input to my patient. We cannot do this alone. It must be through collaboration. Collaborative approach ensures a comprehensive assessment of patients' medical therapy. That's where you now identify drug therapy problems and facilitate the development of individualized treatment plan. We collaborate with healthcare providers to implement evidence-based guidelines, monitor medication outcomes, and promote the rational use of medications. That is why we are there. Okay, next slide. I still continue to, this one is about SPAN and trial. There must be a professional respect, and you must know your boundaries. Otherwise, there will be a problem. You must know your role. You must know your boundaries. What you are in that collaborative aspect of healthcare, you must know your boundary so that there will not be chaos. Very, very important. You must have to understand it. What should be our role in taking care of these patients in this interprofessional relationship, intercooperative, hello,
Hello.
okay. Also, there should be a
So there
professional
could be a professional rescue.
This, I'm hearing
This,
a,
I'm hearing it.
what's the problem?
What's the problem?
Okay. So we must respect other healthcare professionals within our team, and we must know our boundaries. Very, very important. Then there must be a common ground. There must be a stepwise approach to patient treatment in order to achieve that best patient outcome. Recognize professional expertise. Sorry, I'm getting another call. Okay, so to respect other healthcare professionals in our team. Know your boundaries. Like me, I'm a critical care pharmacist. If you are talking about, sorry, oncology, we do have cancer patients in the pharmacy. Sorry. Please, I'll call you back. I'm in a meeting. I always know my boundaries. And that's the only way we can work together as a team. And if you know your boundaries, if you know your expertise, there will be increasing confidence in you whenever you make recommendations, because they know that they're not in your own domain about medication. You're a medication expert. So you should be able to give out sound, evidence-based information in terms of medication.
Ó sì kú àtìkè ẹni
Hello?
kókó ṣe lọ ó sì máa ti ké lọ́wọ́ fún yín. Àtíkè lẹ sọ pé kó mú lọ́wọ́ náà. Ẹ sọ pé kó mú nǹkan makeup lọ́wọ́.
Okay, necessary mentality. Teamwork makes the dream work. You cannot do it alone. Even if as a pharmacist, in my own unit, in ICU, we work as a team. I'm the lead team, but we work together. Even the interns. In your own pharmacy unit, you must be united and have a common goal before you now have to go and integrate yourself into other healthcare professionals. Okay, that's the only way you work efficiently well. Do all that it can to make this work. You must have to be committed. Okay, know about your educational background, context, professional interaction. Some people have low emotional intelligence. If you don't have good one, please pray for that. Because without good communication, there's no way you can collaborate with other healthcare professionals. Even within your own clinical pharmacist, without good communication, that's the key for this collaboration we're talking about. 3 domains of exchange, relationship. You don't have to start collaborative relationship, because you can only sit down to discuss about a patient, recommend, and they will accept your recommendation if they don't know who you are. So the first step for us clinical pharmacists is to have a good relationship, start to initiate that relationship. And if you ask me, if you've not narrowed your practice down as in a one specialty, how are you going to start to relate with every other person, let me say in a hospital, if you're a hospital pharmacist? Like me, I work in ICU, so I already know my own domain. So we see every morning, afternoon, night, we discuss, we always in one seminar room. So we've already established relationship. Because all the healthcare professionals work as a team. They already know, we know ourselves by name, we chat, we discuss.
To navigate the dynamic information environment,
it's not when you want to talk about I'm a
and it's demonstrating a political way of meeting global practices of
with other healthcare professionals.
Media literacy, using the UNESCO category International Media and Information Literacy Institute in Nigeria. It has become imperative.
Okay, so I was saying that we must have to establish, you must have to start a social network with other healthcare professionals. I still insist specialization is the way forward. Because if you're an oncology pharmacist working in oncology units, you can easily know your other healthcare professionals you're working with. You have to socialize, greet in the morning, talk, chat, see yourself in the seminar room. You're already friends. That's the only way you can easily collaborate with other healthcare professionals within your team. Because if they don't, like, I give you a scenario. There was a day one, I say the senior reg or so came into the ICU to see one patient. Maybe he was employed new, so he don't even know who I am. I don't even know him. So after our pharmacy rounds, and we waited for the multidisciplinary round, I don't know what was delaying them. So I say, we can't just continue to wait and see this our patient. We must have to make our recommendation as staff. Okay. So it happened that that patient, we've been trying to correct hypokalemia for over 5 days. The patient had been on an injection potassium chloride. The potassium initially was 1.9, was increased to 2.0. Up to that, it wasn't appreciated. How can we correct potassium for over 5 days? I was still at 2.1, 2.0. So I wasn't comfortable again. So I now told them, let's see what is happening. Okay, we now calculated the potassium deficit of that patient potassium, and we find that this patient is receiving the correct dose of KCl that should have helped him to move into normal potassium level, but still up to 5 days. Okay, so we now have to look forward again, search, and now notice that this patient is a and had been on insulin. So as we are giving the insulin will be busy depleted. I said that multiple round, but maybe it may not be possible for us to you prescribe Sorry, I was thrown out. So he was shocked. He said, yes, we calculated the deficit and the dose you prescribed was correct. He now became calm. He said, okay, what do you want me to do since you know that the dose was right? He said, yes, but look at this outpatient prescription. He's on insulin. He screamed. He said, oh my God, that he didn't even remember that insulin would be busy depleting the potassium as we are correcting. It's okay, pharmacist, what do you think we can do now? It's okay. Since you already know the correct dose to give based on the calculation, we can step it up. You're not asking me, what do you want? What dose? We now step it up by 2. And behold, the next day we got it. That's interprofessional relationship. If earlier, because he didn't know who I am, for others, they will easily assess our country because they know that we know our onions and we collaborate every day. But due to good communication skills, not only that, I have evidence-based information about that case that made him to mellow down, and we work together to achieve our patient's best outcome. Okay, so you must know your onions before you want to collaborate. Very, very important, or else then our profession will be at stake within that healthcare team. Then we have so many barriers that can prevent us to collaborate very well with other healthcare professionals. Okay, can you share my slide again? We have so many barriers, okay? Causes of conflict within the interprofessional working relationship. We have relationship conflicts, value conflicts, data conflicts, interest conflict, and structural conflicts. In relationship conflict, there may be miscommunication, strong emotions, stereotyping, and repetitive negative behavior. Yeah, because different people behave different ways. If I didn't use good communication to communicate with that senior age, I wouldn't get the best outcome for my patient. He may even ignore my recommendation. Okay, so we must know how to communicate. Very, very important. If you have a good intervention, you identify the drug therapy problems, but you cannot communicate effectively, you've done nothing. It's because it's only when you communicate and prefer your recommendations and it will be accepted and our patient will get the outcome. So the first thing you have to know about collaborative practice is communication skills. Very, very important. Okay? Then data conflicts, lack of information. You must know your patient. You must know your patient.
Next.
If you don't know your patient, don't even bother showing up your face. Because you may be,
what are you going to do then?
because you may be looking in one way, you didn't even know the broader aspect of that patient history, both subjective, objective findings. So you must have to know your patient.
When
Know
is
the
this guy going to give you a person?
know the pathophysiology of that illness. The acquainted patient laboratory results. You should be able to read and interpret all laboratory results. Do the prescription so that you can have a good grasp of your patient, so that we now start to collaborate with other healthcare professionals. You can have it to express yourself because you already know your patient. So if you don't have information about it, don't even bother yourself. We have interest conflicts, procedural interest. Sometimes now some hospitals don't even allow pharmacists to have access to patient electronic folders. It's still a conflict of interest and they must have to be tackled, or else how can you be a clinical pharmacist when you don't have your patient information at your hand? Then what are you practicing? Okay. Time constraints. After pharmacist word round, you want to engage in multidisciplinary round, start to collaborate again, wasting your time. It's not time wasted. If it's only for one patient, you must have to do that. Okay. Then we have challenges. Like we pharmacists, I'll move on to go on. We have varying educational levels as pharmacists. Some stopped at just B Pharm, some have their Pharm D, some masters, some fellowships, some PhD. Okay, so if you're working with a pharmacist who just no more continuing education, some pharmacists don't even want to go into the world. What they know is just to dispense medication. How are you going to collaborate with such pharmacists, talk less of the other healthcare professionals? Limited clinical experience. You must have to have good clinical experience to collaborate with other healthcare professionals. Okay, confidence. Some of our pharmacists don't even have that confidence within ourselves, talk less of moving into to collaborate with other healthcare professionals. Lack of motivation. Like some of us that are fellows, up till now, we've not received specialist allowance as consultants. You may not have that interest to give more time or do all those things for our patients. Okay, lack of demand. Different approaches to pay. Then in case for other like physicians and other healthcare, sometimes they have mistrust of pharmacists or even from these. If they hear that you're Dr. This, from where? Doctor of pharmacists, it means what? Lack of understanding of the pharmacist role. Some don't even understand. They prefer that we stay inside the pharmacy and count medications. They don't understand who we are. And it's only we pharmacists that can tell the world who we are by what we can bring out on the table. Okay, different approaches to patient care. Lack of understanding of pharmacist education training. So these are barriers that we must have to overcome. Then I'm moving into communication. I will rush this part. As I said earlier, without good communication, you cannot collaborate. Even within your colleagues at pharmacy, talk less of other healthcare professionals. And we must use maybe verbal, maybe non-verbal, maybe listening and all whatnot. Okay, there must be effective communication skills. You must listen. You want to collaborate and somebody is talking, you don't want to listen to what that person is saying, you just want to say your own. No. Listening is one of the most important aspects of effective communication. Listen very well so that when you want to speak, they will allow you to speak. Okay? Create an environment where everyone feels safe. You must be a good listener. Tips for effective listening. Focus fully on the speaker. Avoid interrupting. Avoid seeming judgmental. Show your interest. So that when you are going to talk, they will allow you to talk. Then use non-verbal communication, very important. Show interest in what other person is saying. So that when it's your turn to talk, everybody will listen effectively to you. Tips for non-verbal communication. Improve your non-verbal communication. Practice observing people. Be aware of individual differences. Look at non-verbal communication as a group. So as you want to speak, you can still use non-verbal communication. Even to your patient, we collaborate with patients too, not just healthcare professionals. This communication skill is very important for you to communicate with your own pharmacist, to your patients, and to other healthcare professionals. The basis for effective communication in healthcare, it is very, very relevant. It will help you to have good coordination. I've moved on. Who needs to know? Notify the right person in terms of coordination. Keep others informed as necessary. What are the proper steps for notification? The relevance. I want to move at
Successful.
You want to provide information, like as the scenario I gave, I waited for us to have a multi-standing round. It wasn't forthcoming. I have to move ahead because it's time. We don't have to dispense another KC of that day, that same dose. And tomorrow again, when they repeat the test, it's still, the hypokalemia is still there. So you have to time what you're doing, do it at the right time. Determine the urgency of the request of what you want to do. Timeliness is also very important. Then follow up. Follow up. Don't just have communicated, like we agree that we are going to step up the dose of KCL to add extra 40 million equivalents. I didn't stop at that. We make sure that he prescribed. We make sure that the pharmacist brings out dispense the drug into the ICU immediately. And we make sure that the nurses administer it. We didn't stop at that. Tomorrow, we follow up to see the outcome of that correction, whether the hypokalemia is still there or is there any intervention again we have to do. So you continue. Especially we clinical pharmacists, we manage our patients, medication therapy management. You cannot do this without collaboration. No way. To your patients, to other healthcare professionals, these have been our main course of work. MTM is a district service or group of services that optimizes drug therapy with the intent of improved therapeutic outcomes for individual patients. So you are trying to manage your patient medication, you assess your patients, assess the medication plans, that's the prescriptions. The ultimate goal that we want our patient to receive the best medication. And you cannot do all this if you don't know your patients, the history, the laboratory findings, you're able to interpret them, and then as well as review the prescription. And you didn't stop at that. After this, you continue to monitor the patients. That's medication therapy management, especially those patients with chronic diseases. Even those of us in the community pharmacy do this very, very well. You have series of patients, diabetic patients, hypertensive patients that you monitor. You should have their files. Every day you check their blood pressure, you document the drug they're taking, you document the counsel you give them. When they come back again, you continue to follow up. That drug you're giving, is it controlling the BP or is not? Then the intervention you must have to do. Or is it a diabetic patient? This is our core area. Okay? And anything you're doing, you must have to document it. In your community, if you don't document it, how are you going to follow up with that patient? If the patient comes back again in a week's time, you ask, what was your BP last time or your blood sugar? I can't even remember. So you must have to document. Very, very important. Follow up. Know when to refer. And so on and so forth. I have one case on MTM. AP is a community pharmacist that has completed an MTM encounter with a patient. So we can corroborate with our patient with good communication skills. Past medical history is a diabetic patient, hypertension, osteoporosis, hypercholesterolemia, arthritis, and COPD. Then AP, who is a community pharmacist, discovered the following: supratherapeutic doses of metformin, carvedilol, lisinopril. Diabetes and hypertension are still uncontrolled after measurements. Then supratherapeutic doses of ibuprofen still there, and there is sign of GI bleeding. Is an ulcer patient. There's an untreated COPD with exacerbation. No rescue inhaler. How should AP communicate these findings with the patient's physician? Can somebody help us to answer this? So we'll move ahead. Still have so many slides. So Hello, are we together?
Yes, we are, ma.
Let somebody help us now. How should AP communicate these findings with the patient's physicians? He's a community pharmacist, though. After reviewing these patients, all these observations were made by the pharmacist.
I think a kind of referral back to the physician. That's if he's been going on to see this physician regularly, we want to assume that the physician is aware, or if not, probably maybe a referral back to the physician as a pharmacist. Is it possible, ma'am?
Okay, you write a note.
Yes.
It's of two ways. It's of two ways. Like for me, in my own community, I have community pharmacy too. Once I see the name of even the signature, I already know even the heading of the prescription, you see the name of the hospital. You can easily access that physician through phone. Then communication skills is very, very, very important. Okay, but there are some patients, if you can't get hold of the prescriber and you want to write something again to go back to the hospital tomorrow, after you give, they'll just leave you, enter another pharmacy and buy their drugs and go. So you have to look at your patients. But if it's in the hospital community, it's a different ballgame. But inside the community, you have to look at your patient. The most important thing is there. You discover that there's supratherapeutic dose of metformin. You've already measured the blood glucose, whether random or still that is not being controlled. Maybe prescribe 500 mg of metformin BD. Then the listener, the hypertension is still there. You do get the patient's documentation as he or she come to your pharmacy. And he's a no-nonstop patient. There's high dose of ibuprofen. So it's of two ways. If you have access to the prescriber, fine, call, give a call. Good communication. But if you don't have, you look at your patient, you know that if you don't have to have this patient, you will to the charlatan there. The pattern medicine dealer, you will not buy all of them and go. So you have to bring that patient into your office, sit that patient down, and talk to that patient. So it depends on your patient. You can go ahead to do the right thing. But if the patient that really knowledgeable enough, you don't have access to the prescriber, you can write something for that patient to go back. So it depends on the scenario who you are communicating with. Are we together?
Yes, ma'am.
You can just help that patient, rather allowing him or her to step outside and enter another pattern medicine store and buy those medications like that. So
I think there's a hand up, ma'am.
Okay.
Sorry.
Let the person talk, please.
Yeah. Good evening, presenter and colleagues. I just want to quickly make a contribution on the case study, especially on the medication therapy management aspect of it. Am I audible, please? Can I go ahead? Okay, all right.
Go ahead, sir.
Thank you very much. The topic of our presentation today actually said collaborative approach. And there's no how you can practice MTM without collaborative approach, because MTM actually believes in collaborative teamwork. MTM believes that the pharmacist cannot do the work alone. The doctors cannot do the work alone. The nurses, everybody will be involved. So in the community, if we have a community practice, it's just that in Nigeria, we have a lot of issues. But if you have a community practice, any hospital, any government hospital or private hospital close to your facility, you should be able to have a relationship with the prescribers in that place. You should have a relationship with the pharmacist in that's close to your facility. You should have a relationship with some of the hospital staff, so that when there is any issue, you can easily contact them. And like the presenter said, communication is key. Even with your patient, you must have that relationship with them. So if you notice anything, you can get across to the prescriber. But because you already have a relationship, you already have that relationship with the prescriber, you can write a note. You can write a note and give the patient, or you can just call the prescriber and discuss this patient. Because MTM believe in better therapeutic outcomes for our patient. Our patient is key, but communication, teamwork is very important in MTM. So we can communicate and have good working relationships, professional working relationships with our prescribers in our neighborhood, especially when we are in community practice. Thank you. That's just my contribution. Thank you.
Okay, thank you so much. Your contribution is quite beautiful. Thank you very much. Please, can we move on to the next slide? I have questions there. So the AP is the community pharmacist. Does AP know the medical doctor? And have they ever had any interactions? As the last speaker said, how significant are the findings? Does this require urgent follow-up and follow-through? What is the means of communication? A phone call, written communication, WhatsApp, etc. So all these questions, we have to understand it and know the right step to make. Relationship is very, very important. Know your team around your area, as he said, so that you can easily communicate, and the person you're communicating with know who you are, knows your onions, you understand what you're doing, and two of you can work together to help that patient. Okay, this one is the next slide about medication reconciliation. Is still one of our duty to reconcile our patient's medication, especially those in transition from one, maybe from outpatient to inpatient, then going outside to the community. Okay, it's still the duty of the pharmacist to do that. This reconciliation is done to avoid medication errors such as omissions, duplications, dosing errors, or drug interactions. So how do we do that? Next slide. We have 5 steps. We have to develop a list of our patient current medications. Develop a list of medications to be prescribed. Compare the medications on the 2 lists. Make clinical decisions based on the comparison. Then communicate the new list to appropriate caregivers and to the patients. Very, very important. It's our core role. Okay, like me, I'm in the ICU. We have patients, a non-hypertensive patient who had stroke. We manage, we'll start, the BP continue to be high in the ICU. Okay, we always ask the caregivers, please, can you tell us the medication he has been on? If they will say lisinopril, losartan, this and this, and information for us, we'll document it. Okay, so during our rounds, we're able to, explain that this patient has been on this medication. Maybe it wasn't adherent or something like that. And sometimes we go as far as telling them to bring those our patient medication to us. Okay, so we'll try to still place that patient on those medication he has been on, the right dose, and monitor it, so that during discharge, we'll still bring the caregivers and the patient. Please, you've been taking this one before. Now, we don't want you to take it. Please don't take it again. Wrap it. You may even throw it out or something like that. This is what you're going to take. Or you are still going to take the same drug as you used to take it before. So they're not the same. Pack them together, something like that. It will help to even avoid overdose, because they may go home and start continuing with the previous medication they already had earlier with the ones that have been discharged on. So we always reconcile our patient medication during admission and during discharge to avoid such errors. Okay. The next slide, part A. Clinical pharmacists review medication profiles with the patient to assure it is correct and up to date. Then in part B, patient will receive a copy of their medication profile. Very important to avoid overdosage and something like that. You discharge him on lisinopril 10 milligram. He has been taking lisinopril 10 milligram at home. You will pack all of them together. So You must have to help them out. So let's see this case, the next slide. JR is a hospital pharmacist that is trying to reconcile a patient's medication upon admission into the emergency room. Do patients know the medication that they're on? Do they have a list? Is there a way to contact the pharmacy for a list of his medications? How will you document the list and keep it current throughout the transitions of care? How will you communicate the medicine list to the attending physician? Is collaboration with the patients and with the prescribers. Pharmacists now mediate. How are we going to do this? Next slide. Pharmacists provide services for the medication management of disease states and patient safety. Some are certified diabetic educators, asthmatic educators, and so on and so forth. Some manage anticoagulation, diabetes, hypertension, and so on and so forth. Next slide. Okay, this is the case now. Next slide. IK is a board-certified anticoagulation specialist and has been assigned a new patient. The patient was prescribed warfarin 4 mg daily post myocardial infarction. Upon visit to the anticoagulation clinic, the patient's INR is 1.5. How should IK approach the need to increase the dose? How should IK communicate with the prescriber? What should be the follow-up time and format? Can somebody try this? Hello? Hello? I'm waiting.
Sakina.
Yes.
Jọmọ tí wà lost, bá mi gbé ojú Zoom yẹn jáde.
Do I go ahead, please? It's like nobody wants to try.
Bá mi
Huh? Okay. The most important thing now, you must be an expert in your own field. If you are not, you may not really help this particular patient. Like we're talking about anticoagulation. Like I'm an expert in anticoagulation. I'm satisfied anticoagulation specialist. Yes, I was trained in US on anticoagulation. Okay. If you're not an expert here, you may make some mistakes. Okay. First of all, what should be the normal INR for patients who is taking warfarin for post-MI? So that knowledge must be there before you can do any other thing. Because of that expertise, the pharmacists understand that INR of 1.5 for post-MI is subtherapeutic, is low. That there is need to increase the dose of warfarin. Okay? Now, how would these pharmacists communicate this to the prescriber? I say come down with a relationship. Relationship is the key. Like in my own unit, in UNTH, most pharmacies, other pharmacy units, if they receive any prescription on warfarin, they'll tell just, please, patient, go to the ICU. Just once they come to the ICU, we will not dispense warfarin without seeing the patient INR result. It's not possible. So the INR results will help us to review the dose of the warfarin we are going to dispense. So like we envisage this. Once we see the prescriber, we already know the prescriber because we work together. We just give you a call. Prof, this is our patient with post-MI. You prescribe warfarin 4 mg and the INR is still 1.5. They will just, Maureen, please just change it. That's what they do. Maureen, go ahead and change. Simple. Because we already established relationship and they know that we are experts on anti-coagulation management. Okay, so for us clinical pharmacists, we must have to narrow our practice down, especially if you're working in the hospital. If you narrow your practice down, have passion for a specialty, stay there, read well, educate yourself, go for training, whether within the country. It mustn't be outside Nigeria. Have a passion for any field so that you are there. You now have a relationship with other healthcare workers working around that your specialty. So that any intervention you want to do, you can easily know that once you see the signature, you know who the person is and give a call. You already understand it. For me, this would not be a problem for me. Once I make that, they'll just change. And we don't stop her. They will continue to follow that patient up. Next visit, we will document that so and so day, the INR was 1.5, and we change his or her warfarin from 4 milligram to 7.5, as the case may be. When the patient comes back again, we'll review, see whether is it because of poor adherence or the diet. Because if your patient is taking vegetable to very high vitamin K, it will still affect the effect of warfarin, and the INR will be affected. So we ask those questions to know where we're going to help that patient, not only drugs. You may even step up the dose of warfarin, but that patient is still taking other drugs that interact with warfarin. Still, you will not achieve the goal of the targeted INR.
Hello, good evening,
Go
madam.
ahead. Go ahead.
I just want to make a contribution. Like in
Go
the
ahead.
other case study that we discussed, we should also take into cognizance non-pharmacological treatments too, whereby the patient that is hypertensive, diabetic, we have to also advise the patient on salt intake, low or either low, or the patient should stop salt intake for that particular period. And then you also advise patient on the type of food the patient should be taking in case of diabetic patients, so that the patients will know that some food can also increase its sugar level. All these are very important when you are dealing with diabetic hypertensive patients. And also, we should also encourage drug spacing. In case of all these patients, since most of them are having multiple drugs, polypharmacy, so that there will be less risk of drug-drug interaction, and then they will have effective advantage of whatever drugs they are taking in our dealings with our patients. I just want to add that to.
Thank you so much. Thank you so much. You still brought them on communication skills. That is, your patient will understand what you're telling him, and important to adhere to those non-pharmacological changes. Thank you so much. Okay. At another slide, I've moved on. Therapy change. LR is a hospital pharmacy that is reviewing a patient's laboratory result and noticing that the patient renal function requires a decreased adjustment of the medication that is being used as to avoid severe adverse effects. How does LR communicate the information to the healthcare team? How urgent does the communication need to occur? So we may not waste more time here because our time is fast spent. It's still the duty of pharmacists to manage our patient medications when there is a renal impairment. Okay, so we look at our patient serum creatinine results, and when we know that they have very high serum creatinine, then the kidney is compromised, that there's need to do renal dose adjustments. Okay, so like in my own unit, we know it's our responsibility. Most of the time, once we see such a thing, then we'll go ahead to calculate the patient creatinine clearance and dose the medications, do the renal dose adjustment, and move ahead to recommend immediately, and always they will just change the prescription. Most of the time, they'll say that they've written a consult for the renal team to come and review the patient. And most of the time, when they write that consult, it may take the next day for the renal unit to come. So in emergency, we don't have to wait till then. So the pharmacists go ahead to do renal dose adjustments, and they immediately dose the patient while we await the renal team. Otherwise, we'll continue to injure the kidney more. Okay, so still communication is the key, but you must still know your onions as the clinical pharmacist. The next slide. PM is the clinical pharmacist that is rounding with the healthcare team one morning and notices after a chart review that the wrong medication was given to a patient. The doctor's handwriting was not clear, and therefore the nurse interpreted the writing to be Levonos instead of Lanoxane. How does the pharmacist address and handle this situation? How can this type of mistake be prevented in the field? Now it's between the pharmacist and the nurses and the prescriber. So communication is still the key. Okay. Pharmacist communication with the healthcare workers, you must be clear, you must provide concise information, be accurate, be respectful to both the professionals and to the patients. Be prepared to elaborate and discuss what you're talking about, and be prepared to provide scientific references. Very, very important. You don't just say, this drug is wrong. You have to bring evidence-based information to prove that that shouldn't be the best for that patient. Okay, don't just say you don't have to. What should be the alternative? What dose should be the appropriate dose? So you must have to provide those information, those solutions to the problem you identify. Don't stop at identifying a problem. You must have to bring to the table the solution, the best approach with evidence base. Please, very, very important. Okay. Next slide. Remember, how we communicate with one another is everything. How you say a thing is more important than what you say. You are an expert, you know it, you understand that that therapy is wrong for that patient. You know from all your reference that this is the wrong dose for this patient. Fine, but how you communicate is the most important thing. Communicate with one another is very, very important, but how you say a thing is more important than what you say. If you don't have a good communication skills, those your intervention you want to prefer will not see the light of the day, whether you like it or not, unless you're in the community. Okay, and we must have to arm ourselves with this clinical pharmacy requirement. Next slide. We must have to know how to read laboratory findings and interpret them. Know about you can't know everything. That's why we must have to narrow our practice down so that you concentrate in your field. Please know how to follow up our patients. And we know our own duty is to review prescription before the prescription is being raised, during the prescription, and even after it has been written. Patient assessment question: does the patient need this drug? I've moved on, please. Is this drug the most effective and safe for this patient? Is this dosage the most effective and safe? Next slide. If side effects are unavoidable, next slide. Does the patient need additional drug therapy for these side effects? Will drug administration impair safety or efficacy? Are there any drug interactions? You must have to check it. Will the patient comply with the prescribed regimen? When they prescribe very expensive drug, you know that this patient cannot afford it. The patient entered into your community pharmacy to buy drugs from, you look at the patient, you see Rosuphene. You look at the patient, you know that this patient cannot. What are we going to do? We have a lot of work to do for our patients so that they have to come out a very good outcome. And all said and done, the next slide. Our aim is to give effective pharmaceutical care. We must have to be sure that to give our patients safe drug therapy. Economic value is very important. Looking at your patient, know what they can afford, effective drug therapy, and overall, we just want to improve our patient quality of life. In any how we can do it. And it is better done where we can collaborate and have good communication skills. Next slide. Yesterday's pharmacy. Yesterday, we were busy compounding, making apothecary period. Next slide. Next slide. We are busy compounding but today, pharmacists, we collaborate. We are patient-centered. We don't work alone, work as a team. Please, let's all collaborate. But you must have to know your onions. You have to be knowledgeable enough, have good communication skills, so that we can improve our patient outcomes, both humanistic, clinical, and economic outcomes. In conclusion, for us to collaborate, start with the willingness of all parties involved in the patient care process. We need adequate time to develop ourselves, knowledge that will be ever evolving. So we have to continue reading. Required commitment for all parties involved. Requires clear role delineation. You must have to know your boundaries. Require all parties to appreciate and respect clinical roles. It's imperative to achieving optimal patient outcome. Clinical pharmacy should collaborate with other healthcare professionals to implement the triple aim of improved health outcomes, decreased costs, and improved patient satisfaction. Thank you so much for listening. I'm done.
Thank you very much, Dr. Maureen. It's been a very interesting presentation. And although it's getting late, but I think if there are any questions, you can raise your hand so that we can unmute you. I think there's someone raising hand already. Ebon, I don't know if you can unmute those ones raising their hands from your end.
Okay. Okay. Okay, they're already unmuted. Pharmacist, when they come out, you have the stage, ma'am. We can't hear you, ma'am.
I've unmuted myself.
Good. Okay, ma'am.
You can't hear me? Are you hearing me
now?
now?
You now, ma'am. Yes, ma'am.
Okay. So I just wanted to appreciate Dr. Maureen for that wonderful presentation and still emphasize some of the things that she raised up. We are talking about collaboration. Even if the information you have is excellent and you don't communicate well, it will be trashed. One, when you are profiling your information, try not to compromise the confidence of the patient in the healthcare provider. I don't know whether you're getting my direction, because there's a way you do it, the person will lose confidence in the physician. It's not right. And when you are presenting your, making your input, don't make the physician feel little. Don't try to show off, I know this and you don't know that. You heard what, the way she communicated, the insulin, the hypokalemia, everything is okay, but because of the insulin, you come from the angle, you know, direct them. And once they, you are just pointing, it will still be his information, but you're the one that brings up the thing that brought up the, at least brought it to the physician to see where the error is emanating from. You are not trying to be little him. You're not trying to make him come true. As I know it, that he will ask you, how much will I eat? Should I take a tank or a drum? So when you come through the, you are bonding with that person. Can you, like one time we had an interaction in the psychiatric ward. The doctor already, when you're there, they feel somehow. When you're there, they feel somehow. So I just went to the doctor. I said, can you, say, what's wrong with your patient? He said, that's the problem. Each time we want to discharge her, it's as if she has relapsed. I said, please, can you look at her neck? Just look at her neck. Already she was, coming up with the side effect of the drug that they were, the neck was stiff. And the doctor, and they easily take the correction. Sometimes we broadcast the error that we find, making that person feel inferior, making that person feel somehow. And instead of collaboration, it's a war. So that is just one thing I want to bring in. Communication skill. She had to mention it time and time again. Communication skills. So let us know how to communicate in such a manner that we do not undermine the confidence of the patient in the doctor. We do not try to belittle the other healthcare provider, trying to showcase that we are important. Everybody is important. Nobody is more important than the other. That's just my contribution. Thank you very much.
Oh, thank you. Thank you. Please, I'm honored and humbled too to listen to my boss. Well, Fam Waneka Bonemash, I'm happy to hear your voice. She was my boss, so retired
I'm
but
happy
not.
to hear you.
She really trained me.
Yes.
So I'm still very grateful. Thank you so
Thank
much.
God. I thank God. And thank you for keeping the flag, flying. God bless
Thank you.
you.
Welcome.
Is it the charger for?
The moderator, you can continue.
Okay, but I think we'll take the second person raising the hand. I did ask Pharmacist Fumila Yoma.
Yes. Good evening, House. And
Good
thank
evening,
you
ma'am.
very much, Dr. Maureen, for the very beautiful presentation. I just want to add to what you have said, that pharmacists too, because we have to read just as you have said, and we need to develop confidence in ourselves. Because even where you are communicating and the way you are saying those things is like you are not too sure. It makes the other healthcare providers to view you as somebody that is not serious. So there's every need for us to have confidence in ourselves, read, work with other members, and develop that confidence. So that by the time you are speaking as an authority. And just like the other speaker has said, important that you communicate properly. She had mentioned it in her presentation. Let us communicate properly. Don't let us make anybody feel inferior by whatever we are going to say or whatever contributions we want to make. Thank you. That's my contribution.
Thank you very much. We can have Pam Ejiro. Please, you can unmute yourself.
Thank you very much for the opportunity. It's a privilege to be in this, to have attended this session. I wasn't expecting anything less. Dr. Maureen has someone I've always had high respect and regard for. Having said that, the whole idea about collaboration, it calls to mind the need for pharmacists to take seriously or develop themselves on the team concept. Today, no matter what the knowledge you have, no matter what the information you have, if that information cannot become useful to the patient at the end of the day, it becomes worthless. We always use the word the healthcare team. The question is, as pharmacists, how well do we understand and appreciate the team concept? Now, first, whether you're in the hospital or you're in community practice, you need to first identify the key stakeholders in a patient care. And this will range from even your patient medicine dealer. You need to acknowledge their existence in any society. It then goes to all the various members of in the hospital, the healthcare team, the various specialties, and even as far as the non-medical staff, because for you to effectively provide care to a patient, you need the services of everyone. You may also need to go to the medical record. So what do we know? How well do we appreciate or understand the team concept? For those of us who are out of pharmacy school, there are loads of free online courses, paid courses that we can engage in to hone our skills in terms of team management, conflict management in the team. Because it is when we are able to appreciate this that it becomes easier for us to contribute as effectively as members of any team, whether we are in the community. In the community, you also have a team. Like somebody mentioned, the hospitals around you, the laboratories around you, even the patient medicine dealers around you, you also need to recognize their existence. Because that is where, like Dr. Murray said, if you just overlook a prescription, the patient can just go to the next patient medicine dealer if you decide to just write to communicate to the physician. So realizing all stakeholders in any patient care, whether in the hospital or community, once you identify who makes up the core part of the team and the external part of the team, then we can then hone our skills on how to reach out, communicate with these ones, collaborate with these ones to improve patient care. And then at the undergraduate and postgraduate training level, I want to appeal to institutions to do more in terms of that administrative, clinical pharmacy and administration department. A lot is done. I know a lot is done about leadership courses, conflict management. We also need to incorporate the team concept from the training level. We see our medical colleagues, you see them moving in teams, in groups, the medical team, surgical team, right from the undergraduate level. So they appreciate what it means to be teams. But in pharmacy school, we do more of individualistic assignments, individualistic practical, such that one pharmacy student does not want to even show the other pharmacy student the material he or she has or the report of his practical. But having gone through training in the UK, I realized that even though you as individuals, you have your individual assignments, you also have team projects, team assignments. And from that level, you already appreciate what it means to collaborate, to work in a team. You already realize different personalities, the fact that each individual has their own strengths and weaknesses, and you understand what it means to depend on the other person, what it means for the other person to depend on you. So I really appeal to our training institutions to do more with regards to team concept and team training from the undergraduate and postgraduate level. And for those of us who are already qualified, let us continue to self-develop and hone our skills with regards to collaborative training, team training, so that whatever clinical expertise we have, we can effectively make use of it. Thank you.
And now, okay, there's one more hand from Ola. Please, you can unmute yourself.
Okay, good evening, everyone. Thank you very much, Dr. Morin, for your wonderful presentation. In fact, Really, really wonderful. So I just have some contributions to make. I agree totally that communication is key, very, very important. Now, another aspect is when you talked about education. I want to say that knowing your onions and being knowledgeable is not something that happens in a day. So I want to encourage us as pharmacists, even if it doesn't seem to be happening in your practice now, just continue. As you see the cases, you train yourself, you read up, you go on for online courses like the last speaker just said. If you have opening for you to get certification, go ahead and do it in that specialty that you like, that you want, you have passion for. It will help us as pharmacists. And then in the area of education and training, I want to refer to what happened in my facility today. I am a certified critical care pharmacist. Now we have a patient that was brought in. He had patient has an intraventricular bleeding, hemorrhage. So he was being scheduled for surgery. And when I walked into the ICU today to do my normal pharmacy checks and rounds and all that, I discovered the patient's creatinine, he was being walked up for surgery with 4.1. So I quickly looked at all his medications. I looked at all of them. They were in order. The only one was the IV omeprazole that was there. So I quickly turned to the doctor. I said, please change this to rabeprazole. It's more renal friendly. He did not argue. And I want to say that it's not because had it been that he doesn't know me and there's no relationship, he wouldn't have changed. He immediately changed that. He asked, is it 20 milligrams? I said yes. He now immediately changed. Now, that same patient, I happened to walk to another unit and they came from theater to pick a drug, to change a drug for the patient. So they had dispensed pancuronium. I didn't have an idea of the other drugs that they had dispensed. And so they came to atriacurium. I said, yes, it's actually supposed to be atriacurium this patient should take because he has issues with his kidney. So when they collected the medication, I turned to the intern pharmacist. I said, please, do you know why they are collecting atriacurium and not pancuronium? They are changing it with pancuronium. So these are the little things we can teach our intern pharmacists. That is why they're doing experiential learning. As you see those cases, you teach them about it. I talked to her about Hoffman degradation, I talked to her about atriacurium being intermediate acting and all that, and having an inactive metabolite unlike pancuronium, which is long acting, removed by the kidney and all that. So in our practice, we should aim at teaching these interns. And I also want to refer to us as pharmacists gradually growing. Keep reading, keep using those resources, keep learning. It's an everyday thing. Once you see a case, read everything you want to read about that case and know it and the drugs surrounding that case so that you can know the medications. Now, I work in the critical care, right? Usually I get calls from different places, OPD and all that. Recently, I got a call from the pharmacist in OPD, said, Famola, please, I'm having an issue with a doctor. A patient has he prescribed levofloxacin for an 8-year-old. So I said, please. And that why I want to say this because it's important for you to know the patient. I said, I need to have an idea of what is wrong with this patient. Now, it happened that I was able to elicit that the patient has chronic osteomyelitis, which requires long-term antibiotic use. I said, please, I need to see if there's an MCS. Now, she said she couldn't see an MCS because we do e-prescription. So she searched through the system, she didn't see. We had to call the lab and they sent us the result. And lo and behold, Staph aureus grew, sensitive to both cefuroxime, a lot of other drugs that were safer. So she said she had approached the doctor. Doctor, he refused because there was no relationship. I called that doctor. And because I used to be on rounds with them before I entered critical care, when I was under the spine unit, he knew me. So when I talked to him, he still was adamant that it's not because of the untoward effect on the tendon and all that it doesn't really happen and all that. It's 1 in a million. I said, sir, it's not just 1 in a million. You don't know who it's going to happen to, So at the end of the day, that is why it comes down to you have to have the solution. I had already done my homework, read up everything. You now say, okay, what do you suggest? I said, sir, you can do clindamycin. It's excellent bone penetration. Good with Staph aureus, including methicillin-resistant Staph aureus. And he said, oh, please, go ahead. What doses? I said, and everything. So what I'm driving at is not something that happens in a day. Let's keep learning. let's keep having that relationship, that cordial relationship, that collaborative relationship. Go on rounds with them, talk with them. Sometimes you may not win. Like the one that happened in ICU like a few days ago. Yeah, a septic patient came in. I noticed that has been on Rocephin. She had bilateral amputation. I said, this Rocephin you are giving her, we already know our resistance pattern in this hospital. You've collected the samples. Why don't we go to Merinon, please? He said, no, I want to do vancomycin and all that. I preached and preached. Vancomycin is narrow spectrum. It's not. I preached and preached. I did not win in that situation. He said no. I said, fine. He said, okay, till the next day, let's do 24 hours and see what happens. But lo and behold, that patient did not last for 24 hours. She died. So all I'm saying is that we should keep working at it and keep, making our input, making our impact. Knowledgeable one. They will not refuse. Thank you very much.
Thank you very much for all the contributions, and it's really interesting seeing there's a lot of work that our colleagues are doing, supporting collaborative care, and kudos to you all, and we hope that every other person on this meeting has benefited from the contributions from the presenter and also other guests that shared their experiences. So over to you, Ebon.
Okay. Thank you very much. It's really been a very interesting evening. We're really happy and excited to have had our speaker tonight. And for everyone that came on board, thank you for the contributions. It's really been a wonderful one. Collaborative patient care, the role of the clinical pharmacist. We actually had it in mind to have it in 2 sessions and even bring in the other healthcare professionals. But we thought before we expose ourselves out, let's have an in-house thing and have not a specialist actually to speak to us. And I can see tonight we really learned a lot. But 2 major things I think we could take in tonight is I think communication. One major thing, the first one, communication. We need to build up on our communication skills, our interpersonal communication skills. And secondly, we need to build up our confidence, our knowledge base. I think if we do these particular things, the sky would actually be our starting point. Yes. Thank you so much, Dr. Maureen. We're really glad and happy for you honoring this invitation and for everyone joining into it. Really, Kaduna State CPAN, you were really excited to have had this caliber of people joining us in. We had a lot of retired directors, deputy directors and all. We had professors to be on ground tonight. It's really been an honor. Thank you so much. We had we could say almost a mini Nigeria joined in here in Kaduna State tonight. We're really honored to have had you. And we also have in our midst tonight our incoming, I will call her our incoming, let's say vice chairman. No, don't know if she's still on. We have is Aisha online tonight. Is she still on? Okay, I can't see her again. Okay. So thank you so much, everyone. Really happy to have had you. And by the grace of God, we'll be having the part 2 of it by next month. We'll all put out the notice again so that we could join in to actually wrap this up. Or looking forward now to actually have other professionals. So we put in together so that this could actually take on full grounds. Thank you. And for the slides, someone asked for the slides. We will make the slides available to be on our own platform. I think probably we'll put it also on CPAN national platform for other people to join in. Thank you so much, Professor Mrs. Bolachiko Unilag. It's an honor to have had you in, and to every other senior colleague, every other colleague in the house. Thank you so much. Thank you, our moderator. You did a very good job. We're really happy. Thank you. Good night. Yeah, I think we have our closing prayers. Dr. Basir?
Yes, please, we can have our closing prayers individually. Thank you. Thank you very much, and good night, everyone.
Good night. Thank you so much. Yeah, Fan Kemi, you wanted to join the CPAN platform? Yeah, I don't know, a clinical pharmacist. Actually, I don't know if you could private chat me. I'll put my number now on this thing. I could tell you more on that. Yes. So that's the number. I'll tell you more about. So that's for you, Pharmacist Kemi. Thank you so much, everyone. Good night. I think we'll be ending it here.
Thank
If you've
you.
gotten the number, I could just private chat me. Thank you. Good night, everyone. And for anyone too that wants to join the CPAN national platform, thank you. Good night.
Good night.